we do the same thing for men. So when I opened up my clinic a few years ago, I also saw the gap in how we approach men's hormone replacement therapy versus women, and we are literally a decade behind. A decade. So we have made all these advancements in men's hormone replacement therapy. They inject, we know how much to give them. We can make them feel great. We don't tell them that they have to wait until they're menopausal, right? If they're like in their 30s and they want testosterone, we don't tell them, "Hey, you have to wait until you're no longer making sperm and then for a year. Let's wait until you're no longer making sperm for an entire year and then we'll give you testosterone." Like we tell women some of the most absurd things that I hear. They don't make any sense, keeping us like suppressed in a really big way.
Hi, I'm Missy Macholka, the Menopause Midwife. I'm here to break down all the things about menopause and hormones that seem overly complicated, which is pretty much everything. With over 10 years of experience catching babies and 2 decades of intuitive massage therapy practice, I have spent the last few years deep diving into all things menopause to figure out why so many women are suffering and why there seems to be so much confusion about hormones and menopause. Calling on my midwifery experience and my desire to help women attain and maintain full autonomy, I will stay next to you during this life transition and help to explain the options as you step into your power and find optimal health. Hello, my lovelies. Today is Friday, June 26th, 2025, and I'm here with Dr. Sarah Daccarett. She is a renowned hormone specialist and anti-aging expert, deeply committed to empowering women to take control of their health and well-being. As the founder of Inner Balance, she has pioneered a transformative approach to hormone management, offering women a convenient, effective, and personalized solution to address their hormones and alleviate symptoms. We all like the sound of that. Dr. Daccarett is passionate about ending the cycle of misdiagnosis and overlooked symptoms, ensuring that women's hormonal health is given the attention it deserves. Her mission is clear: to equip women with the knowledge and tools they need to thrive at every stage of life. I think she and I have a lot in common there. Through Inner Balance, Dr. Daccarett is revolutionizing hormone replacement therapy, or HRT, by providing bioidentical treatments designed for conditions like endometriosis, perimenopause, menopause, and PCOS. Unlike traditional hormone replacement therapy, which was primarily developed for menopausal women, her modern approach can also be tailored for younger women struggling with hormonal imbalances, which is so cool. She helps them to manage their periods and related symptoms more effectively. Welcome, Dr. Daccarett.
Thank you. Thank you for having me.
Of course. So before we hop in, I just want to say that I wish I had had the knowledge that we're going to talk about when I was a younger woman, because I had periods that would end all periods. I would pass out, throw up, miss school, sports, events on a regular basis. And I never had any tools, even though I was around midwives and women's specialists a lot in my life. There was just nothing anybody could give you except for maybe birth control, but that wasn't an option at the time for me. So the 9 months of pregnancy and 11 months of no periods after my babies were born were glorious. And really, I love being postmenopausal in no small part because I don't have a period anymore. So I'm hoping we can circle around at some point in our conversation to talk about painful periods, endometriosis, PCOS. But first, I just want to hear what your story is. What brought you to creating Inner Balance and a product even?
Yeah, thank you for having me, by the way. And it's a great story, and your backstory is great. I hear it all the time, and we don't have, so we should talk about periods and why this is such a huge problem and the lack of solutions for it. And my approach came about, I was just minding my own business. Like I was a pathologist, like in training, went to medical school, pregnant, and delivered my son, and then just postpartum, really the wheels fell off the bus. So I never really recovered postpartum. I was perimenopausal. Like looking back, I probably had problems with my hormones throughout my 20s and early 30s. It was always an issue. Like looking back now, I wish I also had the tools that I have now. I would have enjoyed my 20s more as well. So I think that it's where we keep talking about this later in life, because it's happening later in life, but it's not. This is something that women struggle with their entire lives potentially, or they could have up and downs with their hormones. So I realized that, and we're talking about it now, but like 10 years ago when I was going through it, nobody was talking about it. Nobody. I didn't know, like, it was very much felt alone, or why don't I like this new baby that I had, or why am I wanting to divorce my husband or why do I feel so miserable, and I didn't feel like I still feel like postpartum women do not have the support that they need. We're just basically saying this is how you're supposed to be postpartum. It's like part of having a baby. Welcome to motherhood. And it's not, it's all well, mostly largely hormonal. It would make a lot of sense that it's hormones when your hormones are really high when you're pregnant, and then they drop to like literally zero for a good chunk of time. Or they don't recover. So I hear a lot of women in their 30s don't ever really go back to normal. So when I tried every product on the market, when I finally realized it was hormonal, and kind of really dove into it, I developed Oestra because I had to solve my own problem. So I wanted to make the best thing for me. I refused to feel terrible. I tried all the patches and the pills and the low dose vaginal creams, and I was like, "Can I get like 12 of these?" And like, you just put it all over your body because you realize that these were intended not for a 36-year-old. They're not made for a 36-year-old. They were always designed for somebody postmenopausal, and that's okay. It's just that we've been completely ignoring like the rest of the population. And it's not that we've also been ignoring menopausal women. I don't want to like we're talking about
Mhm.
it now, but we had a solution for them. But there's nothing for a woman who's still menstruating, who wants to keep menstruating, and just enjoy her period. Like, have to, have control of her periods. And so I realized that I had to do it myself. And I was wanting to I wanted to look good and feel good. I had everything in my life. Like, you get to this point in your life where you're like, you've done your career and you have a child and you know what I mean? You want to, like, you deserve it to feel good and look good. And everybody wants it now too. Everything, we deserve it. We do the same thing for men. So when I opened up my clinic a few years ago, I also saw the gap in how we approach men's hormone replacement therapy versus women, and we are literally a decade behind. A decade. So we have made all these advancements in men's hormone replacement therapy. They inject, we know how much to give them. We can make them feel great. We don't tell them that they have to wait until they're menopausal, right? If they're like in their 30s and they want testosterone, we don't tell them, "Hey, you have to wait until you're no longer making sperm and then for a year. Let's wait until you're no longer making sperm for an entire year, and then we'll give you testosterone." Like, we tell women some of the most absurd things that I hear. They don't make any sense, keeping us, like, suppressed in a really big way, and so this was the idea behind. And then Inner Balance is the idea of taking my clinic and putting it online so that, women all over the country can get it, not just in Idaho, because younger women especially, and this is to help them, thrive more. We still have a lot of work to do. We need to make more advancements, and we've been ignoring it because we were afraid of estrogen for so long based on really terrible studies.
Yeah, and I think Oestra is the product that Dr. Daccarett's company makes, Inner Balance, and it is kind of a progesterone-heavy product with some estradiol in it, and that's really amazing because we were afraid of estrogen, but that just threw the baby out with the bathwater too, and so progesterone just went right with it into the scary closet, and, we just shoved the closet closed and never looked at it again. Also, it just brings up the difference between progestins and progesterone. And I think those differences should be highlighted because they're such different molecules. And I don't know if you want to go down that pathway and talk about that a smidge.
It's amazing that, like, progesterone is a woman's main hormone. It's the most abundant. We completely ignore it because we can talk about reference intervals and also the units on the hormones themselves in the laboratory reporting, but it gets completely missed. So women, I can't even tell you how many times I have women, if I had like a nickel for every time like a woman came to me, I'd be like a billionaire. If she showed me her labs and they didn't even bother ordering a progesterone. They didn't even get it. They got like an estrogen and testosterone, and then they told her that her testosterone was low, and that's it. And then her estrogen was normal, and they didn't even get the progesterone, which is like her main hormone. So it's wild that the doctors think it's literally just for the uterus. They think it's just for pregnancy, and this has always been mind-boggling to me how it's so critical for women, their entire health, to have progesterone on board. And the reason that potentially we're missing, like you said, the estrogen is so stimulating in the body, but progesterone modulates everything. It balances it out. So we don't have to be, we have to understand it, not be scared of it. We approach hormone replacement therapy one hormone at a time. And that's the problem too, is that we like, oh, let's just replace estrogen and that's it. And of course she's going to feel terrible if we do that. But what if we just replace testosterone? Her testosterone's low. She's going to feel terrible. Oh, and then like I even see, but then the ones that don't ignore progesterone, they'll just give them progesterone and then she still feels terrible. And women need all three hormones. And this is also the approach that needs to be modernized, where we treating, them like men in the wrong way. We're not tiny men. With men, you can just replace their testosterone. You're done with them. And another problem is that we have created this fake molecule, which we call a hormone. We call it a progestin, which is very close to the word progesterone. And so even scientists and doctors and pharmacists and everybody get confused by it. And so patients are too, of course, women are. Progestin, we don't do this to men. We have not made a fake testosterone, called it testosterone, and then studied it to death, which is what we've done for women. We literally have thousands of papers on progestin, no papers or hardly any papers on our own natural hormone. We don't have reference intervals established in the laboratory for it. And this is really like a sad state for women that we've like done this. And so we keep telling them that progestin is their real hormone. There's no way it can protect them the way that progesterone does. And birth control has definitely made an impact on women. Like, I think I mean, it's obviously liberated us in one way, and then it's harmed our health in other ways, for sure.
Yeah. Well, and I always, because progestin and progesterone are 2 words that are so similar, like you're saying with testosterone, they didn't make a testosterone. I love that. I always tell my ladies, remember progesterone, it has 1 at the end of it, so progesterone is the one you want. That's how I try to help them remember which one it is, but it is misused in the literature and in doctors' offices all the time.
You look at studies, and this is also what confuses doctors because 'cause you'll introduce progestin, and it can raise blood pressure, increase risk for maybe that's what is probably likely, but that's what caused the increased risk for breast cancer, Alzheimer's later in life, heart disease, blood pressure, like, that's the one that's causing all of the confusion and the problems, and estrogen's been pretty much blamed for it all, which is also
Exactly.
really, really bad. When you tell a woman that her own feminine hormone is what is the problem and dangerous to her, that's devastating. You're basically telling her that the problem is her, that being a woman is the problem. And so we don't tell men that high testosterone is bad or you have testosterone dominance, you need to lower your testosterone. But we tell women all the time that estrogen is harming her and that's going to give her cancer. Estrogen, your own hormone, is going to give you cancer. So this has really been sad to see that we've even turned the feminizing hormone into we've demonized it.
Yeah. Yeah, great point. So, while we're kind of looking at that, let's talk about how you see progesterone and estrogen and kind of the balance in your Oestra product. Like, how did you come to what the balance is there?
Women need more progesterone than estrogen. So we don't need to be testosterone dominant or estrogen dominant. We need to be progesterone dominant. That's like where we need to lie. As long as your progesterone is multitudes higher than estrogen, you're going to feel not only going to feel good and look good, but you're going to protect yourself as well from anything that estrogen stimulating in the body. So when you look at every process in the body, it requires both of them. They're like a yin and yang, even blood pressure maintenance. So estrogen will vasoconstrict, the blood vasculature, and progesterone will vasodilate, or something. So they basically will both bind to receptors on the vasculature and maintain your blood pressure. They keep the tone of it appropriate. And this helps prevent heart disease. And you can literally look at every process in the body and they'll be doing the opposite. Estrogen will boost the immune system, progesterone will modulate it and make sure that it doesn't get out of control. We have really complex immune system, neuroendocrine system that is totally different than men, and it's because we have to deliver baby. We don't have to, but we get to, I guess, like, it's one of the most amazing things that body can do is to have a baby and recover from that, but in order to carry a foreign object like that for 9 months, our bodies do have to have a different immune system. So when their hormones drop, it's more devastating. They have, like, depression, anxiety, irritability, they have a lot of mental health symptoms, whereas
Mhm.
men do have they're tired and they're a little bit down, but they're nothing like women really do suffer. So they need to be in this, and testosterone is really important too, I'm not gonna ignore it. It's not like it seems to be the focus, and it's not the main hormone in women. I think we just need to step back and be like, "Hey, can we just get the other 2 right first? Can we get progesterone and estrogen right?" And then testosterone's actually, like, the easy one to raise for women and men, and you can kind of tweak this one. So this one also has to be in the right ratio too. So all 3 of them have to be, but with progesterone the highest.
Well, and I think that you bring up a great point about testosterone. The reason and what I'm seeing in my practice, and maybe I would love to hear your opinion and what you're seeing, is that testosterone can come on board later exogenously, so from an outside source, because we're still making it in our adrenal glands. It doesn't get tanked out like our estrogen and our progesterone from our ovaries declining. So that's what I've seen is like, let's get the estrogen and the progesterone sorted. And I am also a huge fan of DHEA, but I am only a fan of sublingual from Quicksilver Scientific. Yes, this is a shout out to them because that product is phenomenal. So I like to keep that in the mix as well for most of my women. But I don't see testosterone being as important until a little bit later, maybe even closer to 60. Not everyone is like that, but I'm finding that we're getting a lot of wonderful results with progesterone and estradiol and estriol in the right amounts with some DHEA before we even talk about testosterone, which is a prescription and it's can be a little hard to get sometimes in a women's dose.
I think you're right. Like, I think you're right on that it's kind of the why not try to get the other ones and then plus testosterone seems to have the most side effects. So when
Mhm.
you start it first, like you don't know what's doing what. You if you cause something and the testosterone can tend to make women gain weight and be bloaty and have acne. And so you're trying to like reverse all this. So if you introduce it later, like then you can have a little bit more control over that experience as well. I think you're right that the libido women will come to me and be like, I want this libido. And I'm like, okay, well, libido is just one of the other measurements of success. In order for women to have libido, they have to have health. They have to feel great about their bodies. The mental health has to be there. Their skin and hair have to look good. Their vaginal health has
Mhm.
to be there. We need to hit all these other markers first before libido kind of can naturally come for her. And she just wants it to be like the first thing sometimes. And yes, you can get this is like shortcut for testosterone, but it's short lived. I've noticed that when you give a woman testosterone a few months later, she's like, I'm kind of tired of feeling like a teenage boy. And you don't get that lasting kind of natural receptive libido that you might get with estrogen and progesterone. So I think you're right. It's like we can do this later, like the testosterone once we get the other 2, the health ones right.
Yeah, because I always think too, like estrogen is the gas and progesterone's the brakes. I mean, it's just, it's what you're saying. It's like they just oppose each other. We have to have them together. And I have women who come to me and they're like, can I bathe in my progesterone?
It's
Sure.
so it's amazing. Like you're absolutely right. It's like we women absolutely it's critical. It's like nature's everything for us. Benzodiazepine, it keeps us sane. Yeah. I love
Yeah.
it.
I just had a woman in my office yesterday who was, just bemoaning the fact that when she's gone to her doctor a few times, they're like, you just need to go to therapy and you just need an anti-anxiety med. And I, like you, if I had a nickel for every time a woman told me that, it's insane. She literally went last month and they're still saying that. And I can't.
It's actually really sad to see that
Mhm.
that's, like, what they don't see it as a health or a doctors are not trained, like, we have 0 training
Right.
in medical school and residency even, like, anybody that does it, you have to know that a specialist has learned it outside of their training. They've spent the time, they've taken whatever modules and courses and learned it
Mhm.
themselves. So when you go to a traditional doctor, they're just not thinking of it because they weren't trained. I don't even think they're intending to be so harmful.
No,
I think it's just they just don't know. They don't
agreed.
even know what they don't even know what they don't know. So when women are expecting this doctor, they feel like they're gaslighting them, but I don't think the doctors are intending to do that. I just don't think they know.
Yeah, I think you're so right. So, hormones, I think they're kind of the next frontier in anti-aging too. So, like, we're just talking about getting women out of the, I don't know, out of the basement. But what's next for hormones, especially progesterone, but estradiol? What do you see as the future for that?
So anybody, you can do all the cold plunges and hot saunas and injection of NAD you want, and unless and you can look at anti-aging as a pyramid, and the base of that pyramid, 80% of it is hormone replacement therapy. You can do the diet and the exercise, but you're not going to get the results you want unless you have your foundation in place. And hormone replacement therapy, since they regulate and really control, they're like the CEOs of the body, since they do control every process there, you're not going to get that result from the diet and exercise that you're looking for unless you have those in place or at least you've addressed it. And thyroid's there too. It's part of the
Mhm.
hormone, so it's definitely part of it. But in general, it's like biohacking for the masses. Like if you have hormone replacement therapy, anybody can do it. You get you the most bang for your buck. And women need to start thinking about it early and earlier. So hormones are preventative. They're okay, but they're not a great treatment. Like we can't usually use them to treat heart disease, for example, or Alzheimer's. Once those have set in, it's much harder to like reverse dementia. It's so, but when your heart disease doesn't start at age 50, your heart disease starts at age 30 or even younger. And so that's why we like want to do the diet and exercise. But like if you let your hormones be low for a decade before you address it, you are going to create a lot of damage that you could have prevented with just making sure that your hormones were in place, for example. So I think if women were to start thinking about that way, like they're thinking about Botox and phase injections as a preventative, and we don't have to discuss like where we stand on that. It's okay, like whatever your choice is. I'm just saying that you're thinking about it in your 20s. You're thinking about anti-wrinkle stuff in your 20s. You could be thinking about hormone replacement therapy. If you're making sure your estrogen and progesterone are optimal, your face is going to always look great because when estrogen declines, so does your collagen production and elastin and hyaluronic acid, and your face is, and your glow is going to leave, and your skin and your hair are not. So we can even look at it in terms of looking good, which we all want. Like women are spending a fortune on our like hair and skin, right? And so like to look good as we age, and you're doing more in your 40s than you were in your 20s, and your hair doesn't even look as good. So this way, I mean, they just need to start thinking about hormones as protective and preventative. As instead we have this like we talk, this notion that they're scary or something, or I don't want to mess with my hormones, or I don't want to start hormones. We need to have this positive like look on them and start thinking about them as early as possible.
Agreed. In your mind and how you go about this, what does that look like actually for a 30-year-old to start looking at her hormones? What do you suggest as kind of a practical couple of steps for her?
I think practically just to even recognize that it could be, because I think that when you're young, like even I did it, and I did it for like a long time. Oh, I'm tired because I have, like, a two-year-old, and I'm tired because I'm, like, going through medical school and exhausted, or my skin and hair don't look great because I've been doing XYZ, or I need to lose weight because my diet sucks, and so, like, we always attribute it to something else, and we do this for a very long time, or we'll even do it for, like, poor gut health. "Oh, my hormones are all messed up because of my leaky gut," or, "My hormones are all messed up because of my high cortisol." Right? So we even those are symptoms, like leaky gut and high cortisol, those are symptoms of low hormones, right? Those hormones come first. So I have autoimmunity and that's why my hormones are messed up. Actually, you have autoimmunity because your hormones. It's the other way around. So women need to recognize that they're trying to solve a symptom. They're basically treating one symptom at a time instead of seeing the like that they're all from the same thing. So even if they just started thinking about that way, that would help them. So practically, if you have one thing going on, like you just have some acne, maybe you just need to change your skincare, okay. But if you have acne, anxiety, irritability, insomnia, you have to have your diet so strict that if varies at all, you can't sleep for 3 days. If you have to have this really, because I see women in their 30s have to really have this, like, strict regimen in order to look good and feel good. If you're getting to the point where you're doing that, you're becoming intolerant to the things that you used to be okay with. Now you're having to change your workout routine because nothing's working. When you have multiple symptoms going on, this should just alert you that, it's a hormone, because hormones, they will give you multiple symptoms. So like your vagina is very much connected to your brain. Like if you have brain fog and you can't think clearly and you're having some vaginal issues like a chronic UTIs, or you just feel like you have vaginal dryness, but you are having some funkiness, it's like, okay, this is like the start to it all. And then that's just practically like, and then they need to recognize the limitations in laboratory testing. And I think that they can get labs and they can be a guideline and they can work with a specialist and somebody who knows how to, but then the specialist needs to know when to ignore the labs too. So like
Mhm.
you have somebody in front of you telling you exactly what's going on, regardless of what it is a clinical diagnosis. The provider needs to be good. And so if women just those 2 things alone. Like, if I don't go to my dentist for my back pain, like, so why are you going to your OBGYN? Like, why are you going to your PCP who has no training? Men, when their testosterone drops, they'll be like, "Okay, I'm gonna look online, look for specialists to testosterone replacement therapy," right? Because they don't have an OBGYN that they think does everything. Like, women think their OBGYN does everything for them. I mean, it's some of them do. It's great, they're great. But I think in general, if they just knew that they had to go see someone special.
Yeah, definitely. And so is Oestra a product that you would use for someone in their 30s, if they ticked all the boxes for that, or is there
Yeah,
something?
definitely. So, I
Okay.
mean, there's no other product that would really be effective for somebody in their 30s. So, like, if you were to try, like, a patch and a pill, she'd not feel it or notice it. A lot of providers will try, like, cycling oral progesterone in these women, and they still feel miserable. I get told all the time by these women that I've been told I have estrogen dominance, and this is, again, like, it's wild that we've missed the mark, like, hugely on this one. I think providers do this really poorly. So women are, like, they just struggle for, like, a decade before they actually get put on hormone replacement therapy, and then sometimes in their 40s, then the current formulations will work, but a 30-year-old needs more for sure. The younger you are, the more you support you need, because your body's younger, you're more active. Your needs are totally different as a 30-year-old than a 50-year-old or 55 or 60-year-old.
I think you've hit on a word that always kind of pricks me, estrogen dominance or phrase, because I'm not a real fan of that phrase either. I really like to talk about metabolism of hormones, and I think that that is so much more accurate than estrogen dominance because we definitely metabolize down different pathways, and I don't wanna get into the weeds about that because that's a whole nother conversation, but I think if we can support a woman's ability to metabolize her hormones, and one way we do that is by delivery method, which is, mucosal, and vaginal delivery is, transmucosal. And so the people who are listening, my audience, they are starting to understand that that is a wonderful way to get hormones into your body and skip that liver metabolism so we get better results no matter how we metabolize our hormones. Do you have any thoughts about that?
Yeah, I mean, estrogen dominance, you're right. It's like implies that estrogen's high and that it's bad, right? Just the even like the phrase of it. Estrogen dominance. And then we say that plastics, phthalates, pesticides, and all these chemicals are estrogens. And this is also misleading because they're not. They don't look like estrogen, but they do bind to the estrogen receptor. And so when they bind to the estrogen receptor, they prevent your own estrogen from binding, right? So women need to know that if their estrogen receptors are free and their estrogen is low, then you are susceptible to getting all these chemicals binding and your own protective hormone that can no longer bind. So this whole like concept that the estrogens are bad and they're the ones giving you cancer and plastic is an estrogen is garbage. Like I think, you know what I mean? Just don't think like we're just not paying attention to like the way we're talking about it. And this is hurting
Right.
women too, because women just take that as estrogen's gonna give me cancer. Estrogen's really bad. No, plastics are going to give you cancer.
Mhm.
Like fragrances and all of your like beauty products are going to give you cancer. So this is, and we know that that gives you breast cancer, but the estrogen, metabolism, we give the liver a ton of credit, and I don't actually think that women have any problem metabolizing hormones. Like, in my experience, like, they're low in estrogen. And that's the
Mhm.
problem is that we're calling it's just that they're like we were saying, the progesterone is completely absent. So providers will try to help women metabolize their estrogen to get rid of it because it's like the imbalance is so bad because the
Right.
progesterone is so low that they really actually do need to lower their estrogen so that it's lower than the progesterone for them to feel good. Because it's all about like that getting them in the right ratio. So it's the approach is okay if providers are doing that because they're just trying to get them in the right ratio. So when women recognize that they're trying to metabolize that estrogen, it's so that they can try to get progesterone up higher and so that they can get the estrogen a little bit lower and out faster.
Yeah.
Because the ovaries are, like, spitting out spikes of estrogen because they're failing. So we
Mhm.
need to recognize that the estrogen is, like, very much a roller coaster because your ovaries are fatigued, and
Mhm.
so this is also not talked about. Like, we just talk about, "Oh, estrogen's making you overweight and crazy." And so we need that, we're like, "Hey, you're in your period of life where you are not producing the hormones correctly."
Exactly. And so can you tell us how Westra in particular is delivered and why you like that method?
I like the vaginal delivery because it's more stable, and there's this misconception that it's not systemic. We've told women that vaginal creams are not systemic, and this also came about from the fear of estrogen, but we still wanted to give them estrogen, so we told them that it wasn't systemic, but the fact is we gave them an extremely micro dose, so it just treats vaginal dryness. Those low dose vaginal creams are only meant to treat vaginal dryness, and it's just because they're so low, such a low dose that you would never detect it in the blood, but they definitely are systemic, and if you look at peak lab values after you put it even one of those in, you're gonna get, you're gonna see it in the blood. Like you said, transmucosal, whether it's under the tongue or these delivery ways are not new to medicine, like we've known that they are effectively get drugs into the body too. So I like the stable blood levels. I like the predictability of it. I like the ease of use. Like I think it's easier than some of the other ways that we're trying to do it. I do not like the liver metabolism because you do get side effects. Like, I feel like you're getting metabolites that are toxic, and whether they're toxic or not, I mean, I don't think we need to, like, freak anybody out who's on an oral, it's fine. It's just that it could makes you sleepy during the day, right? It can make you bloated, it can give you some of the side effects that you're not wanting, and you wanna feel most like yourself, and an oral and even if you do it under the tongue, you have the potential to swallow it too, right? So you're still swallowing some of it. So, anytime you can avoid the liver, it's better.
Definitely. And so is it typically a daily application or does it depend?
It's usually daily. If you skip doses, you could potentially bleed, right? When perimenopausal women are always, like, already roller coastery. Why would you wanna skip days? So, I mean, like, you're trying to avoid this, like, high and low that you'll see, even, like, throughout the week, you don't want to be, like, going through a roller coaster anymore. So, the more stable you can make everything, the better you're going to feel too, and it's a lot of it's the fluctuations that are bothering women. When you get, like, a large fluctuation, you get a headache. A large fluctuation can bring on, like, a histamine, so this is what we're trying to avoid with a daily application.
Exactly. That's what I always bring up too. I'm like, if you take this for 3 days and then you skip 2 and then you do 5 and then you skip 3, you are creating perimenopause for yourself. So please don't do that to yourself because
You are great.
me.
Yeah, it's so true. You're, like, creating, like, another problem here because you're like, you feel great, and then you feel terrible, and then you're like,
Yeah.
what are we doing?" Mhm.
Yeah, so consistency is key with anything,
Yep.
especially in the peri and menopausal periods. And I guess maybe what I was thinking with that question, and I wasn't super clear, was when you have your 30-year-old, or let's say my 15-year-old who is having period issues, is there a different approach or do we do consistent dosing? I know some people cycle, some people do consistent. What are your thoughts?
So I think that, we need to do more research in this area so that we can maintain fertility. Because we're talking about the reason why we're concerned about it. I'm guessing the reason why you're asking is like the 15-year-old, are we, and the 30-year-old about fertility because we have this impression and limited research that shows that if we have to cycle hormones. These studies are based off of very old radioactive immunoassays, which are outdated.
Mhm.
In fact, any paper that was published today, which used these laboratory tests, would be not even accepted in the literature anymore. But yet every medical textbook and every doctor I ever talked to will say that, "Oh, we have to cycle the progesterone, yes, in order to get the ovulation to happen." So this needs to be restudied. I would even call to the medical community like, "Hey, let's look at this again." So we're under this impression that they have to cycle so that we can maintain fertility and then have that period. So that's why you see women who they'll come to me and they'll be like, "Well, my doctor's having me do estradiol like half the month and then progesterone the other half." Or like there's a lot of, approaches out there, and sometimes they'll get it and it'll work, but I don't think it works for very long because as a woman's aging, this is, like, not keeping up with her needs. But a 15-year-old for sure is gonna be different. So, what is that like, we're getting into the weeds, but it's like, when you have your period, your hormones drop to 0. So, if women understood, like, regardless of what happens during the month, when you have your period and you have that withdrawal bleed, if no egg implants, then you get this withdrawal bleed. And so you can still mimic that with hormone replacement therapy. So if you're trying to, right now the approach is to give that 15-year-old birth control, which is really like, it's kind of devastating that we would do that because we're basically taking that 15-year-old's hormones to 0, which I wouldn't do. I don't have a daughter, I have a son, but I would never give her birth control ever. Like we would have a lot of talks, but like this would be, you're really, doctors don't tell them I'm going to take all your hormones away and potentially impact your health, which it does. And we're doing it, if you need birth control, you need birth control. But if you're doing it for, like, a heavy period, it's not a treatment for that, and so how do you mimic that and still give her that healthy uterus? And so you could do HRT and then stop it, right? So then she has the period, and she's still withdrawal bleeding and turning over that endometrial lining, and this definitely needs to be studied, right? Like, I don't think that the vast majority of the studies are done in menopausal women and beyond. So 15-year-olds, like, address this. I don't think there's a study that exists. At least I've never seen one. It's a really great good question. Very important question because it's a thing. There's no help for that 15-year-old except for, like, you could try to remove all the toxins from the environment for her to, like, try, but even then you're still and are we missing something as basic as nutritional deficiencies potentially in these younger populations like iodine? So, but we don't know because we haven't addressed it. Yeah,
'Cause we just put them on birth control. I can't
exactly.
how many of my daughter's friends who are 15 as well are on birth control for painful periods or to regulate their period, and it's a struggle because she has similar symptoms that I did, not to talk about me, but it's just an example, and, so I have cycled her on progesterone oral,
And did
be
it help?
it is
Yeah.
helpful. Yeah,
Mhm.
and so I mean, I want it to be more helpful for her because she still does cramp and stuff, like, quite a bit, but it's better, and so
Better.
I think over time, once I get her kinda dialed in but I know what I know, and
You know
it's
what you know. It's like endometriosis has been around, like you said, you described your picture, it's almost like, did you have endometriosis? Because it's like
Right.
and is it there's a genetic component and your daughter's, like, struggling from the same thing, and we know that there are genes that potentially are causing this, and so, is the teenager that's put on birth control, and are we seeing that now in their 20s having end up, like, full-blown endometriosis? Is the birth control making this worse? Is it giving these women PCOS? I think we have to ask that question because 'cause we're seeing a lot of them in their 20s, and when you talk to them, they're like, "I was put on birth control, and I've been on birth control for, like, a decade." So
Interesting. I never made that connection.
but, I mean, you're taking away her hormones, her protective hormones, and then you
Right.
expect her to be healthy 10 years later?
Fascinating. That's another conversation. We might have to have that PCOS conversation because I know I have a lot of listeners who have struggled with PCOS or still struggling. Can we dive into the word balance and hormones and what you think about that?
I think it's overused, like, even Inner Balance, I love the name, like, it's like what we or what our name, a company name is, and I think it's appropriate, but I also think we kinda overuse it, but it's really about the ratios, which is why we called the company Air Balance. But I've heard, criticism in that, like, "Well, the hormones aren't in balance, and that's why we have this." But again, do we know that? Like, these are based on very old lab studies, but women are these 3 hormones do need to be the right ratio, I think, for her to feel well, so we know that, like, it get better results with patients when we put them in the right ratio, so what this balance is just about, hey, if you are like, your ovaries aren't functioning anymore, like, let's say they're totally fatigued and your adrenal glands are working, as you mentioned earlier, your adrenal glands are working and you're still making testosterone, that's your highest hormone, then you're gonna be out of balance. So, the balance can mean too, as we're aging and, what if, like, you're on birth control and you've completely stopped the production of your own hormone, and now you're surrounded by these chemicals in the environment that are binding to your estrogen receptor and giving you estrogen, quote unquote, estrogen dominance because they're creating symptoms of like, because when they're binding the estrogen receptor, but they're giving your body a different signal, for example. So the balance is about getting the right, again, progesterone is your main hormone. It should be like the highest.
So, why are women still being prescribed HRT like it's 1995? I mean,
I think I've seen a lot of changes and, like, specialists are getting better at it, and then also that everybody's when I started this years ago, it was like I got the question all the time about the breast cancer, and now I don't get it as often. I think that this is getting out that we've made a huge mistake with that messaging, that was never really the case, and so where we just really have a lot of ways to go. The prescribing practice is like it was, 20 years ago that we have not made any advancements in it. It's almost like it's shameful still. Like we women do not, and even like the bottles and the things that we use are very like outdated. I don't know. It's just because I think we were so afraid of it and doctors. So because of that study, that Women's Health Initiative, like we had a whole generation of doctors that forgot about it. They didn't even oh, it's dangerous, so they just didn't, and they stopped teaching it. I don't know if they ever did teach it, to be honest with you, but
at one point, I kinda dug into that, like, how much do doctors learn? So, even obstetrician gynecologists, they get 2 hours in med school for
yeah,
menopause and perimenopause. That's it,
yeah.
and
And
that's because it's in a women's specialty. So
And even then it's like, "Oh, hot flashes are, this and that."
mm,
And then, like, and it's probably had a bill for it or whatever. Like, menopause and hormone replacement therapy should be its own training, its own residency because it is like a whole body approach, and it does take a long time to learn it. And endocrinologists are also not trained just because they study hormones does that mean they study women's hormones the way that we need them to? And not at all. Like, they sometimes didn't even do thyroid right. They're like a diabetes, cancer, pituitary tumor, like, and we need them for that. There's enough work for that. So,
mhm.
yeah.
Agreed. So I want to shift gears just a smidge and talk a little bit about hormone cascades because you have progesterone in Oestra, and that approach, from my understanding, is that it's going to stimulate some of the testosterone, just like I use DHEA in my practice with progesterone too. But I use that to stimulate the testosterone because it's a precursor, but can you help us understand a little better how progesterone is also a precursor to testosterone?
Yeah, it's just an enzymatic pathway. So an enzyme is there, it converts it. This is just really largely variable. So just like with the DHEA, you can't really predict it. Like when you give somebody a precursor, They might make a lot of testosterone, but that also make a lot of estrogen potentially. You don't know where that pathway will go in that individual. So you might raise her, and then some women don't convert from the DHEA, so their testosterone, so they will get side effects from DHEA too, right? So like I know you found like a good formulation, but a lot of them, it's like you don't know. Same thing with progesterone. The pathway's there, should be there in every woman. Oestra, for example, does not get testosterone very high, which is the point. Like, it's
Mhm,
gonna get you normal, like, normal can be 20 to 30, which is just fine for a lot of women. For women who sometimes they don't like their testosterone to be high, it can worsen endometriosis, it can worsen things. So or if they're cramping and bleeding can get worse. So, for example, like you said, it should be later, or like we should be addressing it kind of separately, or if the DHEA is separate and you have control over that and you can try it and then back off, or let her kind of control that a little
mhm,
bit more. The progesterone doesn't convert. In some women it does over convert, so we would say that we have like women who make too much and you're like, wow, you've made too much testosterone. You can tell it's like obviously over converting. But in general, the hard part is you've noticed it's easier, you feel like you have a better outcome with the DHEA, and I agree with that. Because, like, when I see women who are getting testosterone pellets, testosterone injections, and even the testosterone creams, like, they convert in the skin, like, they aromatize or they'll convert to DHT, and then you get the hairline, and that's where you get, like, a lot of nasty side effects from it. And
mhm.
then sometimes it can get too high, and then what are you doing there, like, with the high testosterone too? You're not making her feel like right, she gets irritable, she can gain weight. So I wanna remind everybody that the units are all different for progesterone, testosterone, and estrogen, which makes us think that testosterone is less important because it's 20 or 30. But when you convert that to the same units as estrogen, it's actually 200 and 300. So this is a substantial amount of testosterone that you can get from a progesterone conversion if you're doing, so it's like
Mhm.
it's there, and but just it's just different because some women need it to be higher to get that libido. Some women like it higher because they feel better. So we should still allow for that individuality. We shouldn't force her into some reference range. Like, she feels great with testosterone of 90, great. Like, okay, so let's see, how can I try to help you achieve that, like, in a really good way that we get that and so it doesn't get too high, or, we still need to allow for women to tell us, like, that I don't like my testosterone high or I like it high.
Mhm.
So, and this is super individualized, I think, testosterone.
Just again, treating the woman in front of you, not a lab number, which labs are fantastic for some reference, or if we're not getting the results we want, we need to kinda dig a little deeper, but for the most part, from what I'm seeing, and correct me if you see something different, but the gold standard is symptomology and being a good clinician, seeing the woman in front of you, and really, I'm just making up a number here, but 90% of the time, you can talk to a woman for 10 minutes and find out where she needs to go, and you're gonna be so close to those labs if you were to guess them, that you don't almost need the labs. If somebody has them, great. They're a great, double check, but it's not always that important, and if we go if we're having a really hard time metabolizing our hormones, then maybe even a Dutch test. I don't think that everybody needs one, and I don't think that everybody needs labs. I think those are hurdles and barriers to entry for hormones that women need desperately. And so I always
I
say start low and slow, and, let's see where we go from there. It is an art, not a science, because everybody's
you're
is different.
you nailed it, and it's also like women are like, "Well, how do you know how much to give me?" And I'm like, nobody knows how much to give you. It's like it's like literally there's nothing out there like some magical crystal ball. There's no lab test. Anybody that's listening, like no provider can be like, you need this many milligrams of estrogen and this many, like nobody knows. So
Mhm,
it's like you have to, like you said, like they have the person in front of you. You start like it's something to be effective. And then you have to, like, it's a relationship. They have to tell you how they're feeling and then you have to adjust it. You have to go back and forth a little bit. There is some like changing of it. The guidelines don't actually say anything about how much to give or what, or even the guidelines say to keep increasing the dose until you get symptom relief, like until you have like tolerance, till the woman feels like her,
mhm,
and then you can even go a little bit above, and then if she can't tolerate it, then you back off, like, this is like the guidelines themselves say that we should be treating to the symptoms, like, is that to your point? Like, they're not really clear on, and it took us a while to even we used to force men into, like, a really low testosterone range as well, and then now we've been more, like, knowing that they actually do need to be a lot higher. We need to get there with women. Like, just to be like, "Look, we're forcing you into this really strict reference range that, like, doesn't make any sense for anybody." And so it's not individualized, it's not personalized medicine. women have to understand that if a provider is trying to force you into that range, they're not being personalized, they're being defensive, and so they're not listening to you, and that can also help you. But the labs are, like you said, they're great guidelines, but it's all
Mhm.
symptoms and what that woman is trying to tell you.
Well, and I just wanna circle back a little bit to the intro because I think you really touched on this, like, we know inside of ourselves how we feel when we're on these hormones, and I always tell women, "Let's find your edges." With the hormones that we're using. So if we're have too much progesterone inside of us, and if you have different reference things that you say, I'd love to hear them. But I always say if we get a little too much in us, we might be a little sleepy or weepy. And so just if you feel that way, then let's back off just a hair. Same thing with DHEA. If we have a little bit too much, we might feel a little edgy. So let's find edgy and then let's back down a smidge.
I think that's actually the best way to do HRT. Like, I know it sounds
Yeah.
like and anybody listening is like, "You guys are crazy," but it actually is the best way because, like, that's the only way to be individualized is when you're like you said, you kinda push them, and then they tell you that, "Oh, okay, it's alright. We found
Mhm.
your" like, it's like a two-year-old trying to find the boundary with mom and dad. They'll just keep pushing,
Yes.
pushing, and then once they found that boundary, then they back off, "Okay, that really upset mom and dad, like, I found that boundary." And
Yep.
so this is just where you want because women, you don't know, like, because they're so different. But you're right, like, you if a good practitioner, like you said yourself, you should be able to recognize if she tells you, "I feel this and that XYZ," you should be able to say, "Oh, I think I know what that is." Like, "I think I know which hormone is doing that or what we did here that's, like, making you not quite right," and then you can adjust it. And so, the standard way of when you go to your OBGYN and they give you a patch and a pill and a low dose vaginal cream, which is, like, kind of the standard way of doing it or whatever, you're not going to get that kind of feedback. It's just like, "This is it, and this is what you get." So going to the provider that can kind of, go back and forth is really key to having that experience for sure.
Yeah, I've been known to cut a patch. So
I hate patches, man.
I
It's like
love patches, actually. I'm kind of obsessed with them, but I know that everybody has their opinions
but
about them,
it's going to
but
the providers have they know their
mhm,
formulation, they know it, like, they know how to
mhm,
predict it, they know, like, to get good results, and that's the key is, like, that you have experience and that your patients are gonna feel and that's what
I
women need to find, is that
yeah,
somebody that will cut the patch up, like, or somebody that will help you get into those right ratios. Okay, well, I can tell that you're not in the right ratio. Let's work on your metabolism here and add something here and, like, do what you can. And otherwise, like, the traditional doctors do not take that same they don't think that way. They think of it's just like any, "Well, I gave you 50 grams of I gave you 10 milligrams of Lipitor, so your statin so your LDL needs to go down." They think that it's, like, so linear the same way, but hormone replacement therapy is definitely not like that. And so that's why I think it's harder for other traditional doctors to get on board with it a little bit. It takes time. It
it's
takes
so
time.
true. It does take time, it takes a little back and forth, and it takes really listening to what a woman is saying, and I wanna talk about for 1 second this theory that I have. I have no data to support it, but I'm curious what you think about it. So, I think that along with metabolizing our hormones, we metabolize them kind of like we metabolize calories, and what I mean by that is I notice that when women are really sweaty or really stressed or burning a lot of calories because they just have something going on, they burn through their hormones a little faster. So let's say we found a sweet point and then they're like, I don't feel that great, or I didn't feel great last week. And I say, well, what happened last week? And they're like, well, I was training for a marathon and my miles went way up, and I just feel like my body's falling apart. What I'm noticing is that we just learn our bodies well enough that we bump up a little bit when we're sweating a ton because we're burning through our hormones almost like calories. Am I off the mark? Do you think there's some validity to that?
I I think you're, like, right on. I don't think of it that way, quite that way, but similar and that you see the same thing that it's a resource, and if you're running a
Mhm.
marathon, you need more, like, to support your body. And
Yeah.
then so, like, if you it's just like if you're gonna eat food, you're gonna need more food if your demands are greater on your body. If you're sedentary and you're not doing as much and you're 60, you don't need as much as, like, a 20-year-old who is running a marathon. So I completely agree with you, and I've also noticed that women who, like, they're like they feel great for months, and then all of a sudden they come to you and they're like, "I feel terrible, I have these symptoms," and
Yeah.
you're like, "Well, what'd you do last week?" And they're like, "Well, I did a giant fast." That's another one too,
Mhm.
like, women
Yes.
be fasting at all,
Yes.
period. We've been telling that they're fasting to lose weight, some of them are fasting for longevity, but I think most of them are fasting to lose weight, and so then when you fast like that and you don't get your protein intake, you like, I don't know if you end up just burning the hormone, like as you described, but there's probably some pathways there that get ramped up during a fast, and
Mhm.
so burning through the hormones a lot faster. So if and then they're like, "Oh, you're right. I just, like, skipped my entire day of meals, and then I felt terrible the next day," like, symptoms of perimenopause came back, and so anyway, they realize if they get their intake in, that stops viruses. I've seen viruses do it, like, if you get a viral infection, they'll like, whatever reason, I think it's thyroid, you get, like, an adjustment of thyroid as well, and then you get something that also seems to burn that hormone, and they get symptoms. So we have
Mhm.
not studied. I think
Mhm.
viruses may impact, like, they'll even get, like, a huge period that they normally don't get
Oh,
after, like, a
interesting.
viral infection. So, like, what is the virus doing here? Is it creating obviously, the viruses we know create inflammation and impact immune system and impact the thyroid, and it could be impacting your estrogen and progesterone pathways as well too. So it's like we again not studied women. So anybody out there, it's like we're speculating because it's not unstudied, but
Yes.
we need to study it because we're seeing it. Like you said, you see it in your clinic. I completely agree with you that it's like we have metabolism of hormones. I think they're genetic. I think that we have different
Mhm.
pathways besides the liver, a lot of pathways besides the liver that we like need to investigate. So I completely agree with you that even if you get it dialed in, that the woman still needs to do certain lifestyle, like knowing her body, like lifestyle things to change. Like if it's not fasting, like eliminating fasting, for example, that could be something she needs to do in order to have good results on HRT.
Mhm. So with Orestra, if let's say, a woman knows she's gonna be training for a marathon and she's got these big weeks ahead of her, so she'll probably be burning through it a little faster. Can she double dose herself? What would you how would you guys
Oh,
respond to that?
Oestra Oestra is built for a younger individual who's burning faster, right? So that's made for younger women. So it's like you're a marathon runner trying to pass on a pill is not gonna work for you, ladies. Like so you're gonna need like so Oestra is like essentially designed just for this kind of a thing. So you'd have to be like really fast metabolizing, really super, which we do. Believe me, I think there's like 30% of the population that we're missing that do this
Mhm.
super
Mhm.
efficiently. So this, I think it's exciting because I think if like the progress that we can make in the next 2 or 3 decades, like as we you know what I mean, just even the research that we can start doing, and it would be fascinating to see if we could find these like genetic links and how we can help her more, like knowing that like we can personalize HRT even more if we knew this
Mhm.
better. Like if
Yeah,
we knew these metabolism aspects, and I'm not talking about a Dutch test and urine metabolites, like, I just really don't think there's, like it's very limited testing if you ask me. So, like
mhm.
but if we were to look and we were to know SNPs and epigenetics and how
Right.
this woman is truly metabolizing, I do not think that, like, Dutch test tells you how she truly metabolizes it. So, if we had this information, though, before we started HRT, I would be like, "You're gonna need more than yeah, than your friend, or you're not gonna need it in this way we could make it even more, and this way we could predict it a little bit more."
Right.
That would be helpful. That would be super helpful information for a provider any provider before starting. And then you're not, like, 6 months in trying to figure it out and just listening to the history and what's going on with her, which is what we're doing now.
Right. Right.
Mhm.
I just want the listener to know, so Oestra has its very specific dosing, and then, what I'm using is more adjustable, if you but we're not starting as high, and so I want people to know that there are options out there. There's not just one and done for anyone. So if something you've tried isn't working for you, try Oestra, have a consultation with me, and,
Yeah.
you know, have the conversations and see what works for your body because everything doesn't work for everybody. So, take the power into your hands and find the thing that works for you. Find the practitioner who's actually listening to you and then learn so that you are the boss of your body. Not me, not Dr. Sarah, not anybody else, you. Because this isn't that complicated. It's actually pretty straightforward. I think a
Yeah.
lot of times they try to make it I don't know who "they" is, but
Yeah,
medical
it feels confusing. It does feel like we're making it confusing for women.
does, and there are parts of it that are more involved for sure, but you don't need to understand the hormone cascade and take a test on it. That's not what this is about. You need to know how you feel and relatively which hormones are off maybe that are causing that feeling and those
Yeah.
symptoms.
Like, we just need options for women because they need to be
Yeah,
able to, like, know and work with a provider that knows the options, and that's what they need,
right.
women need.
And a
Mhm.
provider that isn't stuck on their option. That's the other thing, because I find a lot of times people will only be familiar with pellets or only be familiar with patches or only, name all the things. I want a suitcase full of things to mention to my ladies, even if I don't do it and even if I don't make a penny on it. I want my women to have options. And I think that you fall into that category too. I see this in your passion. Like, let's help all the women feel better because the better everybody feels around us, the better world we have.
Hey, you know that saying, "If you take care of the woman in the family, you take care of the family." Like, it's the same thing with society, like, if women and society feel good, like, we're even talking to it's gonna translate through the workforce, like, everything will be better if women are feeling better.
It is so true. And I know we have just gone down all the rabbit holes and it's so much fun. Let's kind of get close to wrapping up. Do you have any upcoming initiatives or research on the horizon with Inner Balance?
Soon, we will have some publications out, which will be fun and interesting to look at, and so we do have a lot of stuff coming over the next, like, 6 to 8 months, and you're seeing us grow with a new website and new products and peptides, meeting women where we need to in their journey, right? Like you said, like, if we're working with the provider and, like, we just try to meet you what your where your need is, and so you'll see us expanding over the next year into different products as well, and so it's very exciting. I don't have, like, other than saying that, probably shouldn't give me too many details. Fine.
Okay. All right, fair enough. But keep an eye on Dr. Sarah's Instagram. She is a great poster. Her reels are actually really engaging. I enjoyed checking them out when I was doing my research for our podcast. Can I ask you a few rapid fire fun questions? What myth about hormone health drives you crazy?
I think we talked on it, like, that estrogen dominance and that estrogen's dangerous, like,
Mm,
drives me bonkers.
yeah, definitely. What is the weirdest hormone therapy or treatment you've come across in your practice?
I feel like I've seen it all,
I
at
know.
this point. I do. Yeah, I don't know. I don't know if I can answer that one.
Okay, all right, fair
Yeah.
enough, no problem.
I don't wanna get, like, otherwise I'll be, like, start bashing, like, all this, like, it's all good. People are just trying to help. That's the thing too, I don't wanna, like,
It's true.
providers are just trying to help, and so I don't wanna, like, say anything negative because they're truly doing their best, I think so.
Fair enough. No, I totally agree. But this one is really a little more heart-centered. If you weren't pioneering hormone health, what field might you be working in?
This is, like, such a passion and purpose, like, I can't imagine doing anything else. So, like, now that I've pivoted, it's like, I don't think I could do anything else. I've done consulting for hospitals, I've done all different types of, medicine fields, and this has been unbelievably rewarding, so I just wouldn't do it again. It's just, like, all the steps and all of my your mess becomes your message, and so, like, the mess that I was in my mid-30s, like, it definitely, like, this is where I was intended to be for sure.
I love that so much, and I have not heard your mess becomes your message. I love that. I've heard the passion, but I love that one so much. I might have to steal that one. Is there anything that we haven't covered that you'd like to mention today?
I don't think so. We covered a lot, and I really appreciate your, helping like get the word out and educate women. It's such a cool and important thing, and so thank you for that.
Yes, of course. And I have one last little fun thing. If you were stuck on a deserted island and you could bring any 3 to 5 products with you, but that was it, what would you bring with you?
Like I would take hormone replacement therapy. Like I cannot imagine living without it. Like I would
Mhm.
literally you'd have to pry it out of my dead cold hands. Now that I have it, I would never want to like be without it. And then I still like have a few. I guess we're talking like supplements and peptides or something, or are we just talking
Anything you want.
like, just items? Like, of course, I would take my nine-year-old son, like, he'd have
Oh,
to come
yeah,
with
yeah,
me.
no,
You know what I
people
mean? Like,
no,
besides that
no, your products. Yeah, yeah, either supplements or products. I know one of my guests was like her lotion. She was like, I cannot live without my lotion."
I don't
So
know, I really like my sleeping night guard. I'd probably have to, like, go take that with me as well, right? Like, you know what I mean? Just, like, to sleep well and, like, all the things. It's so funny. I would honestly, the HRT, feel like I could probably live without everything else.
yeah, agreed, 100%. That's awesome. Where can our listeners find Inner Balance and find you?
We're on 44 states. Telemedicine will soon be empty, and it's online, www.innerbalance.com. And so you can get more information there just if you're doing research and just want to learn more. Or the social channels you mentioned, we try to put as much education up there because I know women are doing their research. So I mean, just there's blogs and you can check us out there, or you can also get started and then see what it's about too. And we can answer questions as we go as well.
And they have a great website. I will say I did pop through that and kinda check it out, and so it's full of wonderful information and help. So I just wanna thank you so much for being here, Dr. Sarah. It was great to meet you today, and I look forward to what the future holds. And thank you, ladies, for joining us today. If this episode made you rethink everything you thought you knew about women's hormones and made you go, share it with a friend, subscribe, and leave a review. Thank you so much for joining Dr. Sarah and I here today on the Menopause Midwife. Be well. Thank you for joining me here today on the Menopause Midwife. If you'd like more information or to work with me, feel free to check out my website and book a wellness consultation at ohm406.com. Be well.